And then, then we generate this much more tidy form, because once you got those information, then I code them into either risk factors, complication, and some target value. These people all come back actually 4 weeks to 6 weeks later. And then, we triage them back into either the primary care or back into our DM clinic, the more complicated one, or in the others or internist clinic. And then we book them every 2 years, right, in order to really like a QA. So basically really trying to do what St. Vincent's do. So we teach them the self-management as well as give them the logbook. At that time, we actually extracted some of the key information of complication screening, and then together with some of the rights and roles. So that was it. That was the beginning. So, 5 or 6 patients, and then gradually it was like 10 patients, 12 patients every week. And so the register start building up. So that was really used in order to triage care. That was really the main purpose of that. So we've been doing this quietly in our own hospital for about 5 years. But meanwhile, we actually, of course, start analyzing the data and so forth. And so that was really in 1995, we set this one up. And then meanwhile, we also started running some master courses and also diploma courses, and then train some of the nurses and also dietitians, and some of the GPs also join in order to really let some more people understand what we are trying to do, so that we have a bit more partners, right, who buy the idea. And after 5 years, I think people start noticing what we are doing. And we have because we belong to the university, but importantly, that was one of the sort of consultant, which is in one of the public hospitals. And then she then said, well, we should be doing this as well. So that's how they actually start asking the hospital authority, right, to actually train diabetes nurses. So that was very important. So they started this scheme, because even at that time, we might be at the danger of losing our nurses, because the nurses have to go when they become a sister, they have to go back to the ward. But then actually the HA, the hospital authority, they listen, and so they created some career path for diabetes nurses. So these people don't go back to the ward, they stay in a diabetes center. And essentially they do 4 things. They run this QA program, the structured assessment, and then they do the education, all the titration, instant titration, finger pricking, etc. And then also provide liaison between the doctors and also the patients. So that really is gradually, of course, it takes time for them to train the nurses. So now we have 18 diabetes centers, which is scattered all over Hong Kong, providing that sort of support. And then so essentially they adopt this protocol and then put into their electronic medical record system. And meanwhile, we actually also did quite a lot of PhD program, mainly with pharmacists. And basically, once we got the register, and then we were able to identify high-risk individuals. And that was in part because I was also involved in a lot of kidney study, because I started with enalapril versus nifedipine study. And gradually, I was involved in the renal study, and then we noted that a lot of the diabetic kidney disease patients. And so we use the register to identify these high-risk individuals. And then, we use this pharmacist and doctor team, and then really ensuring that they're treated to multiple targets, reinforcing a lot of the adherence, making sure these people are put on drugs, etc. But these patients are all identified from the register. And then, so I think, again, we publish this data, we tell them, the HA, and I think they listen. So they really buy in, and then they actually use a lot of paramedics to help. And then we take it further, and that is, by then we have already recruited more than 6,000, 7,000 patients, and then we link it up to the electronic medical system, and then use the ICD code to actually define all the hospitalizations. And then we develop a lot of risk equations, and in 2007, we digitalized the whole thing, and then put it in a portal, which is consisting of all the templates. And then, once the data are in, then we were able to risk stratify, and then also show some of the, the trends of risk factors together with a lot of decision support, and then again, give it back to the patients. So 2 years later, I think the hospital authority, again, they now want to roll it into the primary care. And so they actually, again, use the whole concept, because now they have already set up the infrastructure for nurses to conduct this kind of complication screening. And then they use this data again to divide patients into 4 categories in order to triage them. And as a result, this is now really a program that is widely implemented in both the primary and secondary setting. And because they use this structured assessment, so we have a very good database, and that database formed the Hong Kong Diabetes Surveillance Database, so that we were able to reevaluate, what is the outcome. So that was really the story. But of course, it is not just the register. I think it is really the whole system and the ongoing evaluation that kind of reinforce some of these messages. And then when the ministers also see the data, that they really are seeing people reaching better targets. And more recently, when we actually look at the data and see that they are all actually reducing outcome, I think they like it, right? Because I think they all have to deliver, right? So all these managers, they also have to deliver, and they thought, oh, this is already a available solution. The academics have sort of shown it works, so we just have to give them a couple of nurses, give them a room, give them some equipment, and then with that electronic medical record system, they collect those data, and then give it to the academics to actually evaluate, and then try and reinforce that that thinking. So yeah, I think that was really the register in a nutshell. This is the latest one where we actually look at 0.5 million people between 2001 and 2016, and we could see that actually this is the whole group, and you could see that the 3% death rate has all the way come down to 1.5% death rates, more so in the elderly. But we found that actually the concern we now have is actually more the young people. It hasn't shifted a lot. So currently we're running a couple of programs actually targeting at these young onset diabetic patients, which are very complicated. But not just the death rate, but also all the diabetes complications and also acute infections as well.
So if you were to mention or the really the key factors that make a registry successful. So the registry in itself is not going to help. So you mentioned you need support from the health authorities, and the health authorities need to be smart people, you mentioned. Are there any other factors that make it work?
But the thing is, I think they look at data, because certainly for us, right? For example, because they are the NHS, right? I think that applies very much to Europe as well, because they have to pick up the bill, right? They know that every year, dialysis is going up, cardiovascular outcome, hospitalization are all going up. And so when they actually see a group that actually systematically showing that using this integrated care, which are very much data driven, right? Then I think they see the value that, and they have tons of resources. They do. I mean, they have a lot of money. And the point is, so they also understand that it might not be sustainable. So they do it like a pilot project. And then, of course, I think along the way, of course, all the endocrinologists and also diabetes nurses also lobby support.
Yeah.
And so then, we run courses to train nurses.
My final question, maybe Massimo has a few follow-up questions as well. So if you were part of this working group in Europe, what would be your main recommendation? So how can we be successful in replicating what you have done in Hong Kong?
I think firstly, you do need a champion. I think you need a doctor first. I think at the end of it is still a medical problem. I think if you have a couple of doctors, do a couple of pilot scheme, and these doctors should be given a little bit of support, right? I think a nurse is important who are trained to do this, and then really start actually re-engineering the workflow, right? If you have a system, I mean, even just an online system, right? And then just getting those data, and then reevaluate at 1 year. And then see, and then just refine that little logistics, right? Because obviously every place is different.
Because you need a champion, you need a listening health authority, you need a dedicated team that can translate the ABC values into new recommendations. And you also need the people in the field following the recommendation and implementing what you are saying. I think you have done absolutely something fabulous in Hong Kong. And I really enjoyed speaking with you about it and learning from you. And I really do hope that we can replicate at least some of it in Europe as well. But Massimo, do you have anything you want to follow up with?
Yeah, of course. I mean, first of all, congratulations. You have reached the St. Vincent Declaration target. So
Yes.
they were realistic. It can be done, but it takes time, much more than expected. So from your narrative, we can really learn a number of lessons. First of all, that's which are the main factors for what you achieved. First of all is continuity. You have been running the system for now nearly
a career, 20 odd years.
A career. You dedicate your
tell you
career.
My wife will tell you my age already, right?
But now you have the satisfaction to say that the system is mature enough that will survive your career. So this is something. This is the breaking point. Now the system. It would cost much more to to cancel your system, the system that you have created, than to return to what was before. But also, what is necessary is the commitment, and then there is the need for commitment and enthusiasm. Rob asked, how could you convince pharmacists and so forth? I mean, you convinced the pharmacist with your enthusiasm, I believe, because you believed in what you were doing. So, and the other point, which is extremely important, is that this has been a low-cost, progressive evolution and not a revolution. You began by asking very little, and then you have been smart enough to adjust. You have not been asking for billions to build, a new system, but you have been made this system grow with small resources. At the end of the story, they invested quite relevant resources, but when they were, well aware that this was working, and then it was, profitable to invest. And the other point is that, of course, you did demonstrate with your trials, and then you used research, and actually they were not, I would say, absolutely new findings, but they were, scientific findings on a local basis. So you did demonstrate that, just taking care of blood pressure, according to a research protocol in your setting, could produce benefit in your setting and not in the settings of a paper published who knows where. But also to put together all the different pieces of your research, and then to build the integrated care based on these research protocols, and then, based on local evidence. And this is something that is convincing. And the other point is that I believe, from what you say, you have been adjusting to the needs. You knew which could have been the needs, to the opportunities. I believe that you have been extremely pragmatic in define how to adjust to the different, but also to take into consideration the barrier. The other point that you clearly demonstrated is that registry is a fundamental part of a system. It's not a standalone, target. The target is not to build a registry, but it's something around which allow, a system to evolve. So if the system is not evolving, then the registry is not necessary. It's not necessary. It's useless, and then it's not producing. And the other point is how to motivate, the general practitioner. Well, we are not considering one of the factors of the rewarding, concept in our professional. We do consider that money is the most relevant factor. I still believe that the professional satisfaction is again one of the main factors. At the end of the day, if you deliver better care, I mean, and you satisfy the people you are, taking care of, this is even more powerful than money. So this is some of the concepts, and it takes time. It takes time. I mean, we cannot. I mean, this is something that we have to consider. Having said that, all the factors that can facilitate and then can promote this evolution of the system, they takes time, and they do depend of the different local environment.
Not be ignored, and data require response. And you really have been very successful in making that loop closed in Hong Kong. You also were able to engage all the relevant parties, whether you were invited or not to do so. So I think being a champion made a big difference, and being at the right time, of course, also definitely helps. So
but all your supports are so important.
I know. So I really would like to thank you so much for this very, very nice opportunity to talk with you, and having Massimo as the big data-driven person in Europe.